And I'm going to make it very practical. And if there are people that want to make comments at the end, please do so. I'm not going to talk about electronic magnetic navigation bronchoscopy. It sounds terrible to talk about something like that. Now, we use, the bronchial, the flexible bronchoscope, fiber optic bronchoscope. Usually I do the sedation and then I do the bronchoscopy myself, and then I wait for the surgeon to come and do the bronchoscopy. It's like being a little bit scallum, you know, because they sometimes take a long time to come. And it gives you a little bit of extra time for anesthetizing the airway. So we're lucky we do it in the scope theater. A scope theater means we're doing it outside the operating theater. But I mean, it's inside the hospital. We're lucky people. We are about 20 meters from the ICU. We are about 20 meters from the intensive care unit. So we feel a little bit more comfortable doing it there. But there is no anesthetic machine in the room that we would do it. Now, what sort of issues? I just want to run quickly through that. ASA classification. Do you think they're all ASA 1s? Wow, ask Nora, they come in there and they sit upright, and you know, the oxygen saturation is 70%, they cough. Well, you can think what you can see. We're going to say a little bit about the drugs we use, what sort of patients, monitoring. I'm not going to talk about monitoring. I've just left that for you, and that is monitoring. Proper ventilation should be assessed with end-tidal capnography. I'm not going to talk more about it. I haven't got time. Then we're going to say something about clinical cases, disease state, and then I'm going to say something about something I think we as anaesthetists forget about. Transmucosal administration and absorption of drugs. All right. Post-sedation problems and during procedure, not a lot about that. Now, what are the issues? Selection of patients. We see anything from 1 to 4. Coming in there with a saturation of 70%, sitting up. We don't want them to be sitting up. We want them to lie down if possible. They're on many different drugs. I can't go through that. Our procedure is usually 20 to 30 minutes, usually lavages or foreign bodies or some, well, short procedures. And then I'm going to tell you about it. They ask you to come and do a bronchoscopy in the ICU with a tube in, you know. That's quite challenging. Okay, which techniques? There are various ones. I mean, you can tell me, I mean, this technique will not work. I brought Nora here to tell you whether it does work. Don't forget, even if that patient is coming to you from ICU or wherever, you still got to do a pre-sedation assessment. You got to look at the airway. I'm going to show you the airway now and what we do with the airway. And quite often they're obese patients. Well, that's not so easy, but we do them. Now, the use of topical anesthetics is recommended, that's American Committee of Pulmonology for basic and advanced bronchoscopies. Now, I don't know if you know that one, because that would be interesting, people talking about gag reflexes. Successful suppression of the gag can be achieved by spraying 1% lidocaine over the area that I'll show you on the screen there. Now, we're using lidocaine 2%. Well, you know, it works well depending on certain things. I'm looking for this tetracaine. It seems to me this is the best sort of local anesthetic for bronchoscopy patients. And please remember that what I'm telling you, other people may do it better. It's just this works. What about the pharmacology? It depends on the indication and the complexity. Basic bronchoscopies you can do on a minimal or moderate sedation, but sometimes we get difficult ones where we got to do deep sedation and take the consequences of deep sedation, which I will not discuss now. Okay, now I want you to listen to this one, because this is something that we neglect, the availability of the bioavailability of transmucosal drugs. If you thought about it, how many of you do nasal administration? Not many people, but there are things that influence it. There are things that influence what I give in terms of lidocaine, and we give a lot of lidocaine, a lot, not so much. So I'm going to show you which factors will lead to you making a success of spraying the airway from the mouth, well, right into the trachea. There are those, and I'm going just to run through, the time is running out. Which factors? The drug, obviously. And the molecular size of the drug that you use is extremely difficult. And I think it's between 100 and 120. I'll get to that now. The second one is lipophilicity, you know that, and the drug concentration and volume. Now, if you do it in the nasal way, quarter or half a milliliter of the drug is absorbed well, both sides. But if you give more than that, it goes down the back of the pharynx, and it doesn't work. Now you've got a volume of, well, we normally give about 250 milligrams of lidocaine. So it's a huge volume, isn't it? So we've got to look at what the particle size is. The particle size, the best bioavailability should be in the region of 10 to 100 microns, because that adheres best to the mucosa. So what I'm saying to you, there are many devices, but choose the right device. Otherwise, you don't get the benefit of that. Smaller particles, you will now go into the lungs. The larger ones will land in the pharynx, and then, well, hopefully to the stomach. Now, this is something you need to think about this morning, because I haven't got all the answers of this. But the mucosa which you work with will depend, will sort of, well, tell you, show you how well is your anesthetizing of the bronchial tree. We're going right through the bronchial tree when we anesthetize it. And this is quite a challenge in doing bronchoscopies. The drug delivery system characteristics, check it when you buy it. I'm just scanning to it. Now, this is the one that we use, and this is the MAD device. And you will see there, it can bend a little bit, because sometimes you don't see the opening of the larynx. You've got to go behind the epiglottis, and I won't say guess. Yes, sometimes we guess, you know, where is that place. And it does help if somebody pushes on the cricothyroid, because then you can see more or less where the opening is. We don't give more than about 5 milligrams per kilogram of lidocaine without adrenaline. Now, in the next one, you will see the advertises. How does that spray look like? Well, it looks quite nice. It seems to be able to anesthetize the rest of the airway and also the bronchi. Now, how do I prepare for a bronchoscopy? How do you prepare for a case? What I do is I'm there on time, and I don't go straight to the cupboard there and draw up my drugs. I first check whether I have the equipment to meet an emergency, and then I take my emergency drugs out of the cupboard, come and put it behind me with a syringe and a needle. So if I need it, I don't run around. You know, one gets excited, you may miss, run out of the door or some place like that. And I'm going to say something about that. You will see there, simple things. Have a look, you know, things like an ambu bag. My son was telling me, he's a physician in Melomet, that 2 days ago they had the regenerator stopped working. And they found the people that put the generators in, and they couldn't find them. They say they're not on duty after hours. So they had to go to the ICU with ambu bags to ventilate those patients because they couldn't ventilate it. So look for your ambu bag. It's a nice thing to have. Look at the airways, the bite block you must have. I always ask for 40% oxygen, rebreathing, nebulization. This is all the things I don't need to tell you. And if you look at that emergency drugs, you will see adrenaline, succinylcholine. They stimulate you to think, why do I have succinylcholine drawn up with cases like that? Magnesium sulfate, like ketamine, the favorite, all available. Saying there, look at the practice appraisal protocol in the SARSAC guidelines. It tells you everything about the drugs. Now, what about the patient? No pre-medication? Well, you decide about that. It's rare that we give them pre-medication because there are so many drugs when they come there. You know, they come there on propofol and, well, position of the patient, I'll show you. Remember about extension of the neck, pillow under the shoulders, good for the airway. Nasal oxygen we give to all the patients. Usual monitors, and then a little bit about the drugs. What about pre-sedation medication? People say you can give midazolam. I don't like midazolam. I still remember I had one young man of 27 and I couldn't get that patient to breathe. And then I found out my assistant, he took the syringe with midazolam and he used it as a spray inside the bronchus. I'm a little bit against midazolam. This is interesting for you, like in clonidine. It's not a routine practice. Some authors suggest pre-medication with oral clonidine to blunt the cardiovascular response produced by bronchoscope insertion, which is quite interesting. It protects against potential arrhythmias and myocardial ischemia. Okay, this is how it patient comes in. Remember, I got a lot of people around there, not watching me, watching the case, and everybody's got something to do. The one will put the monitors on, the one will put the saturation on, all things like that. So I get the patients say like that. The first thing I do patients like that. They're anxious. We give them 20 milligrams of propofol. Do you know how nice a drug is 20 milligrams of propofol? Let somebody give it to you and you see you become a little bit more smiley. And I use propofol not as a TCI here. I use it what the English call the thumbs up technique. And that is giving propofol. So that patient, first thing you will get propofol, you will see what is already on there. Now this is the xylocrine spray that we're going to use to anesthetize from the mouth down to the larynx. Now remember, one spray is 10 milligrams. So we aim sort of for 5 to 6 times. Sometimes we get a spray that's working well. We test it before the time, and then when we use it, it doesn't work so well anymore. Okay. I chose a nice airway. Isn't it nice, this one, to give them sedation for? But I chose it to just show you where we spray these patients. So before I spray, 2 milligrams, 20 milligrams of propofol. Spray the tongue, say, close your mouth, tell them it's going to be better. Open the mouth, spray the back of the throat. Before I do this, I use 5 milligrams, only 5 milligrams of ketamine. All right, from here we're going to the areas which is a little bit more uncomfortable, so I usually give to them exactly 50 micrograms of L-fentanyl, 50 micrograms. And you can repeat it again. That's a very small dose. Do you know what the sedative dose of L-fentanyl is? 5 micrograms per kilogram. So before I get to the end, the epiglottis, I will give again 5 milligrams of ketamine. So that's sort of the drugs that I need. Now, I just want to show you, there is the epiglottis, and we are on our way to put that into the MMA device into the trachea. And why I show you this, sometimes you're not certain whether you're at the right place. If you get in here with your MMA device, you often hear the grr, grr, grr. That means you are against the tracheal wall there. Okay, if you think that a patient, a normal patient, may not have an elongated, I love the word, epiglottis, this is what I sometimes get. I remember about 2 weeks ago I did a case for a cardiologist, and he had that TEE that Reinhard talked about, and he couldn't get the scope in. I was giving the sedation. He couldn't get the scope in. So I remember seeing this in bronchoscopies, and I said to him, can I give you a hand with this? And I took the laryngoscope, and I just lifted up, and you lift the epiglottis up. When you put the laryngoscope in, and the scope went in just like that. But in obese patients, watch out for that one. Now, this is where we start, and you will see just a little bit of spray, 5 milligrams of ketamine. Have a look at the patient's eyes are open, the patient is comfortable, there's enough people around that can help, and everything is just nearby. Now, I'm jumping to that. Remember now, I spray there. Remember, I've given about 10 milligrams of ketamine by then, 50 micrograms of alfentanil, and in between maybe 20 milligrams of propofol to settle the patient. Now, that's how it looks like. Don't think this is how you see it every time. Sometimes you've got to go behind that by bending, or somebody putting his hand on the cricothyroid to open that area for you. Now have a look there. If you look well at that, you see right at the bottom there, it's more or less the opening of the larynx. And there the tube, or the med device, is inside so that I'm just showing that we give it slowly, and I want you to look that we are very careful that we're not hurting the patient. See my finger there, sort of keeping away from hurting or causing problems to the patients. Now, once the fiber optic bronchoscope is in, I give another 100 milligrams of lidocaine into the side arm of this bronchoscope. Now, I want you to look and see how this mucosa looks like. It doesn't look very well. All right. Sometimes we say things like this. This is where you get quite acute laryngospasm. One of the reasons why I've got saxametodium ready for the week. Now, I want you to look at this, and this is the therapeutic blood level of lignocaine. Do you know that it's a good analgesic? It's got anti-inflammatory effects. It's an antithrombotic. Side effects you will see, if you get a patient who is suddenly getting jerks and things there, you must think that you may be between 1.5, between 6 to 10 micrograms per ml, and that's too high. Now, here I'm just saying that you can also give it as an intravenous solution. I want to show you this. We need a bite block, but sometimes when you make patients deeper, they don't want to open their mouth. Have you seen that? You get that a little bit open, and what we find works well is we take an airway and put the airway in and turn it on its side. You can use a smaller airway also, and it opens the mouth for you to go into the mouth. This is quite interesting. This is a hot lung. Have you heard about a hot lung? Those people smoking in they're in the Transkei, a lot of people smoking inside their homes, and those are the ones that do not absorb the lidocaine very well. That's normal. I'm just skipping that. Now, I wonder how many of you know the MAD 72-9 laryngotracheal mucosal atomization device. Now, I haven't taken a picture of the whole thing. That is a wonderful thing if you have an obese patient, because it is quite difficult. And there is a spray right at the top there, and if you put your lignocaine in here, you can put it inside the mouth, and then you tell your patient, listen, take a nice and deep breath and spray the rest of this. It's got a nice spray there, and you can repeat it. So if you cannot get the area there anesthetized, remember about the MAD 70-29. Now, I don't want you to hear my voice here. That's why I'm a little bit, I thought we shouldn't do this. This is in the ICU, and you will see I'm there at the spot. It's a special one where I'm going to measure whether that bronchoscope can go into the trachea. And what is for me interesting is that so many cases I see as people, adult people, only got a 6.5 or a 7 endotracheal um, tube in there, and you cannot get a bronchoscope through a 6.5 or a 7. And then you can give your lignocaine and everything that I've mentioned. Okay, complications I'm just going to skip. This is very rare. The sort of complications that you can expect is bronchial spasm, especially with all the fluids going in there. Anticoagulants, I heard about five days before aspirin. Well, the societies say if you're on aspirin, you can carry on with the bronchoscope. If you're on Plavix, you've got to wait 7 days. And I'm trying to do this in another 5 minutes. I'll rush a little bit. That is my mixture. This is ketofol. I'll say something about it. That's my Dazzlang, which I more or less never use. That's my propofol, and that's my L-fentanyl, 15 micrograms per cc. So you see, everything is drawn up. Which drugs? Well, sedatives. We've talked about my Dazzlang. I've told you about the thumb drug, and that's 20 milligrams of propofol. Why do I like it? Half-life, 4 minutes, 5 minutes. You can repeat it every 4 to 5 minutes if necessary. A little bit further, I'm not going to go through all of this. I'll just tell you this is the mixture of the L-fentanyl. I've got 50 micrograms per cc. I added here, don't forget about the felgam. And this is just saying with the LA, it may be unpleasant, the laryngoscope and the molecular and lifting up the epiglottis, that's why I use it. And it strains. In adults with that sort of dose, Nora, we don't get any sort of problem, 50 micrograms. Right, I'm nearly there. Why do I use it? Well, Marie did say something or other about it. Rapid onset, peak effect, and after 15 minutes, you've still got 40% in the circulation. I'm running through this. This is my mixture of ketamine and propofol. That's a 1 and 2 solution, a ratio we will call that. And I put 50 milligrams into 100 milligrams of propofol. Then I say there is 5 milligrams cc and then 10 milligrams cc of propofol. I was in a meeting last year with Harvard. We were discussing difficult cases, and one of them put up a name and said, James, you haven't got 10 milligrams per cc propofol. That's less. She's exactly right. I said, okay, can we settle for 9.5? In any case, that is the mixture. I'm not going to say anything about tramadol. I'm a good fan. But somebody said something yesterday about, Vickers said something about antidepressants. Now, I think he mentioned it. Never use this drug with an antidepressant. You will get a serotonin syndrome. And I think there's one case reported death after this. I'm nearly there. Why ketamine? Well, I like it. Sedative analgesic, it's safe as a bronchodilator, it protects against hyperventilation, and I like the safety of the drug when properly used. I've never had, believe me, a serious effect with ketamine. Why? Not because I'm clever, it's because I'm giving small doses, and I believe in top-up if you need it. Now, I'm not going to say about that. I said I will say, but time is running out. What about succinylcholine? This is a quite interesting drug. I mean, you will say it needs to be in the refrigerator. Well, there are people saying it does not need to be in the refrigerator. There are people that say it can be out of the refrigerator for a day. I don't know. I draw up that drug, and I'll tell you something that works. If you draw it up, you got 5 milligrams per cc. If you got a laryngospasm, 5 milligrams cc, it will not give you apnea. If I've got a problem getting the MAD device in, I showed you there a difficult area, I give them 5 milligrams of scopolamine. Why do I give 5 milligrams? Do you remember in what sort of order relaxation of the muscles happen? Yeah, from maxillofacial down to stomach muscles and so. Never gets there, that's scopolamine. And the other way around to reverse the action. So I have scopolamine there, and I use it sometimes. Well, not so many times, but I do. And then I am going to, I think, conclude with this. I did well by doing it in quick time, I think. This animal belonged to a prominent president in Africa. And that president fled outside the other world. I think he was put in jail later for something. Maybe it was because of this animal they found in the flat in Africa. And this animal was more or less dead. So near Patterson in the Eastern Cape, they've got big game reserves, and they've got, let's call it a hospital for animals. And this animal was there. So my wife and I came there, standing behind, and the man walking with us there said to us, well, just be careful, he likes to eat, human beings. And what strikes you about that animal? And it reminds me a little bit of what Cherie said yesterday. That animal is showing you, okay, one, that's the way to open your airway. It shows me something about, I am a lion. I can face life after going through severe uncertainty in my life. Thank you very much.